Everyone, Cameron Eldred here, doctorate in athletic training student through Indiana State University. Today we're going to be going over my myofascial release technique comparison. Specifically, we've been looking at a couple of different myofascial release techniques over the past couple of weeks, and these are the two that I really wanted to pick up on. They're both kind of more specific within a larger idea for each of them. The strain counter strain kind of taking its idea from the passive positional release techniques, and the active release taking its position from, of course, the active assisted positional techniques and active positional techniques. They're both very specific, but they're both very prevalent, at least in our field and our niche of physical therapy. So I apologize if you can hear my son. He's running around right now. So the first thing that we're going to be looking at, of course, is the strain counter strain technique. So the biggest thing for this to remember is that it is more for spasm reduction, reduction in pain and inflammation. And of course, this does come from positional release therapy. So I kind of wanted to talk a little bit about the reasoning behind where this came from. It's a therapeutic technique that uses position of comfort for the body and its appendages. It uses its tissues to resolve what we would consider a somatic dysfunction. The muscle is commonly shortened during this treatment, of course, and then after identifying the point of discomfort, you leave them in that position, and this allows them to feel that relief. Within this little niche of manual therapy, it's important to remember that pressure doesn't need to be applied to the specific area. And also to remember, positional release therapy is not, or it is the opposite of stretching. So if a patient has a tight, tender area, say on their calf, the clinician would need to traditionally, they would dorsiflex the foot and stretch that calf. They would get those muscle fibers to tighten up and to lengthen. Now, this could lead to muscle guarding, cramping, spasm, which in turn would lead to pain. However, using that as an example, a clinician who uses this passive release technique would place the tender point in the position of greatest comfort. So for a patient with calf issues, this would be plantar flexion, of course. This would then shorten the muscle or that tissue in order to help them relax. And a gentle and passive technique, which is PRT, has been greatly advocated for the treatment of acute, subacute, as well as chronic somatic dysfunction in people of all ages. So even though PRT was discovered more than 60 years ago, and strain counter strain has been a part of that, it still hasn't been really delved into a whole lot by the medical community or even the public. And it's mostly because of the lack of high quality clinical trials, since those have only just begun. And this is because the technique was originally presented and has been considered as cumbersome or difficult to utilize on a regular basis for practitioners and healthcare providers. Next, we're going to be looking, of course, at the active release. But I apologize, I forgot to talk about theory here. So basically what we're looking at is the activity between the muscle agonist and the antagonist, which is also known as, this is known as the proprioceptive theory. It's the most common theory behind SCS, which is the strain counter strain technique. And according to this theory, the proprioceptive theory, rapid stretching injury stimulates the muscle spindles, causing reflexive agonist muscle contraction that resists further stretching. However, when a reflexive counter contraction, so a counter strain, results from pain-inducing withdrawal, quickly reverses the aggravated movement, and thereby excites the antagonist muscle spindles. Basically, what this is saying is that the neuromuscular, like this results in a neuromuscular imbalance. This is perpetuated by the opposing muscle spasms, and each one is unable to release due to an ongoing muscle spindle excitation, which can affect myofascial mobility and force transmission around neighboring joints and muscles. Now, it's important to remember that underlying muscle imbalance can persist long after the strain has healed, with lasting motor impairment. Of course, this is many times evident along the trapezius, which is what a lot of these articles have looked at. So this is basically based on the neurophysiological regulation of muscle spindle activity that increases muscle spindle activity and reflexive muscle contraction upon lengthening and decreases spindle discharge and reflexive contraction upon shortening. So by passively shortening the dysfunctional agonist muscle long enough, SCS allows normal muscle spindle activity to return. So we're allowing the proprioception of those muscle spindles to get back into place. And once this agonist muscle spindle activity is reset, the antagonist muscle spindle activity can also return at a resting state. So this helps relieve that neuromuscular activity and restores that normal function. So that's a little bit about the strain counter strain technique. This is something that I've actually not used a whole lot in my personal practice, but again, it's been really interesting to read about, and I've learned about it. It's just not something that I have a whole lot of time to apply. But I would like to try to apply this with more of the patients that I'm working with, especially those who are active in baseball and overhead activities, as it pertains to the trapezius. Next, we're going to be looking at the active release technique. So the biggest thing for this one is this is a soft tissue method that focuses on relieving tissue tension through the removal of fibrosis adhesions, which can develop in tissues as a result of overload. A lot of the times this is due to overuse, repetitive use, whatever you would like to call it. These disorders can lead to muscular weakness, numbness, aching, tingling, burning sensations, stuff like that. ART has been reported to be both diagnostic and treatment technique. However, there's little evidence regarding the effects of ART on various pathologies, with a lot of the available evidence being more anecdotal and based upon case reports. And as we know, case studies kind of sit there on the very bottom of our evidence pyramid. There's just not a whole lot to them. So these tissues are prone, the tissue in the body is prone to this negative trauma. And so during a treatment, the clinician will use this manual therapy technique to apply compressive, tensile, and shear forces to address repetitive strain injuries, cumulative trauma injuries, as well as constant pressure within tension points within the muscle. The clinician applies deep tension at the area of tenderness while the patient is instructed to actively move the injury site from a shortened to a lengthened position. So you want to start them in a shortened, comfortable position and have them move through a lengthening position while you are putting high pressure or deep tissue pressure on the point of pain, or near the point of pain. So a few pilot studies have reported the effects of ART on different pathologies. Again, these studies don't have a control group, and the group numbers were absolutely just tiny. However, there was a really good article that we read recently about the adductor strains and ART, and the pilot study evaluated the effectiveness of the ART to relieve short-term pain in the management of adductor muscle strains among ice hockey players. So pre and post measurements were significantly improved, demonstrating that ART was effective in increasing the pain pressure threshold in adductor muscle pain activity or sensitivity. And although the study, understandably was short term, we were still able to see some positive results. There's also been a couple of research articles written about hamstring flexibility specifically one that looked at 20 different subjects that were significantly more flexible after an ART treatment. But again, small group sample, and it was young, healthy males, which limited the validity, especially when you're looking at a general population. Again, it was also only a short-term study. It's also been shown to help with carpal tunnel syndrome, quad inhibition, things like that. But again, small groups, evidence isn't high. So yeah, ART's been used, for a multitude of different things. It can also help improve performance, as shown by a couple of different articles that I read on my own. So when we're comparing and contrasting these things, so this is where we can really look at the two. So first comparison is going to be goals. Pain reduction is going to be number one all the way for both of these. We're trying to get the patient back into a comfortable position for themselves. Next is going to be looking at movement. Of course, we want the patient to have full range of motion. A lot of the time, what happens is these painful trigger points, these points of fascia that have adhered together cause significant pain and reduced movement. So what our biggest goals are is, of course, getting rid of that pain. Let's get them moving. Next is going to be looking at the contrast. So when you look at the pain reduction mechanisms between the two, I talked a little bit about the theories. You were able to see that one of them focuses more on the muscle spindles, whereas ART is a little bit different from that. Active and passive, of course. So, ART, you're going to get the patient moving, whereas passive, it's exactly what it sounds like. It's a passive movement. So the patient or the clinician is going to be putting them through those kinds of the movements that you want them to be going through. Next is going to be the points of treatment. One of them, you are not putting pressure right on the point of pain. The other one, you are putting pressure. So, you don't put pressure versus you do put pressure. So again, looking at those reasoning behind the effects on pain, pain reduction has been shown to be successfully accomplished within both these on multiple locations anatomically, but specifically on the trapezius. So unfortunately, not a lot of research has been done on correlations between all of these different treatments. So we don't know what the effects would be on, if somebody was doing both of them, one of them, what the lengths of time are, things like that. Specifically when it's on two of the same anatomical locations. However, again, as I mentioned, a lot of these are focused on the trapezius. So yeah, that is my, technique comparison. I apologize for it being kind of random there. I had some computer problems earlier this week. So I had to kind of rewrite this and do it all from scratch again at the end of the week. But if you have any questions, feel free to reach out. These are my references that I use. So again, thanks so much.